That's it.
Excellent.
Just
All
let me
right.
say that.
I am delighted to be here today for our 15th annual research day from the Department of Medicine. I am just absolutely thrilled to see so many people in person for this, and we have a fabulous day scheduled. We're going to kick it off with the grand rounds. I also want to make a plug for our communications team, because today they're looking for people to come and talk about why research is so important. And in this time and in the threats and challenges to biomedical research, it's more important than ever that we tell our stories. So please leverage this opportunity. It is going to be in room 1203. And Clint has promised to Photoshop you all so you'll look beautiful in whatever media he chooses. Correct? Correct. Yes. I also want to thank our co-chairs of Research Day, Drs. Blair Golden for hospital medicine, and Dr. Andrea Galmazzi from endocrinology. Hopefully you'll agree with me by the end of the day that they have assembled a fabulous itinerary. There also is going to be cake cutting at noon to celebrate our 15th anniversary. So make sure you stop by. Tons of posters to highlight the amazing work that our department is participating in. Goes from cells and DNA all the way across the spectrum to community-based participation. So go take a look and see of all the work that we're doing. So with that, I am going to introduce Dr. Blair Golden to introduce our special guest speaker.
All right, everyone. Well, great to see everybody. It is my pleasure to introduce our guest speaker today, Dr. Wes Ely. Dr. Ely earned his MD as well as an MPH from Tulane University School of Medicine. He serves as the Grant W. Little Endowed Chair in Medicine and is a physician science and tenured professor at Vanderbilt University Medical Center. He is also the Associate Director of Aging Research at the Tennessee Valley VA GREC in Nashville. He is a founder and co-director of the Critical Illness, Brain Dysfunction, and Survivorship, or CIB Center, and is truly one of the worldwide pioneers in the investigation of delirium and long-term cognitive outcomes after critical illness. He has had continuous NIH and VA funding for 25 years and over 600 peer-reviewed publications. Dr. Ely is also the author of a work of narrative nonfiction entitled Every Deep Drawn Breath, from which he's donating 100% of net proceeds to help COVID survivors and family members rebuild their lives. With that, I turn it over to you. Thank you so much.
Good morning. Everybody hear me okay? Fantastic. I'm pretty stunned that this room is full because nowadays everybody's on Zoom and it's so nice to see eye contact and people here in the room. So I appreciate you being here. And what an exciting thing to be hosting a research day. Research, where we learn things that nobody else knows. Isn't that neat? That nobody in the world knows. And you and your people here at the University of Wisconsin are going to figure out things that can help change care for people all over the globe. And for me just to get an eye on this today is a privilege. So thank you for allowing me to be present. I'm going to tell you a story that is going to show how a simple-minded person who can't possibly do this on his own was able, and I have non-attribution for this work, because is able to get some things accomplished because of the team of people around you, because of mentors who can shape and mold your thinking, and then together we can come and make a difference for other people. My disclosures are on this slide: the funding from the government, the absence of any other funded pharmaceutical, et cetera, work. I did some work with Pfizer and Eli Lilly during COVID, unpaid. I did not accept any honoraria or consultancy fees for that work. It was purely a thing for COVID. And I'm going to tell some stories during the talk today. I take HIPAA very seriously, and all of my stories have written, signed permission, explicit permission from the patients and families to use their stories, so no HIPAA violations. In fact, for my book that Blair mentioned, Every Deep Drawn Breath, there's even a website with all their pictures on it. It's fascinating. So when you read about the people and their quotes, I record their stories. I'm a narrative nonfiction writer, and I record their stories and I transcribe their stories verbatim. So any quotes in the book or anything that I say today will be directly from their mouths and be something that I'm trying to share their love and their lives stories. I'm going to describe then difficulties balancing this technology versus whole person care that all of us are struggling with right now, especially with AI. I call it screen time versus eye time. I'm going to explain a scientifically proven method, which Ed Vasilevskis, by the way, your chief of hospital medicine here, helped to develop and helped to publish. I'm going to share later in the day multiple of his papers and how he helped shape this literature, and what a great thing Dr. Schnapp did in recruiting you, Ed, to Wisconsin. And I'm going to harness the power of human story as a hopeful path forward for us in medicine. So yes, I am a geriatric intensivist. I was trained by Bill Hazard, one of the fathers of geriatric medicine in the United States. His is the classic textbook of geriatric medicine. And for the past 30 plus years, I've been working with the GREC in Nashville. I know you have a GREC here in Wisconsin. And I consider it a privilege to advance the science of aging brain disease. And that's weird because I'm a pulmonologist. So you'd think I'm a clavicle to diaphragm person. And what am I doing up here in the neck up area? But I think that I brought a different set of eyes, because when Dr. Schnapp and I go through the doors of the ICU, we have a different lens than does the typical geriatrician who's studying dementia. And in fact, I'll go on to show how this works later, but the NIH now has a term for aging brain disease that resulted partially from, they cite our work from this New England Journal paper we published in 2013, that because we said basically there's a lot of dementia out there that's not related to Alzheimer's disease, and I'm not just talking frontotemporal or multi-infarct, because this is a dementia that zips up in a week or two after critical illness. And so the new term now that we go under when we go to the NIA is ADRD, Alzheimer's disease and related dementias. So we study RDs, related dementias. And right now we have a $30 million grant indeed for long COVID-related dementia that's in our RD. And when I wrote that grant and submitted it to the NIA, I said, in a nutshell, hey, when 10 years ago our work changed the term to ADRD, we could not have anticipated that there would be a pandemic that would leave, Akiko Iwasaki at Yale says 400 million people with long COVID globally. I think probably in the 80 to 120 million people with long COVID, but hey, it's kind of monopoly money when you're dealing with that many people with dementia. And these patients that we study really do have an acquired dementia. And so the NIA said, okay, yeah, you're right. This is a once in a generational opportunity to study an acquired dementia that came about from a pandemic. And we refer to these diseases post-infection now as IACCs, infection-associated chronic conditions. Think long Lyme, think post-flu, SARS, IACCs, infection-associated chronic conditions. So it's a research day. This is part of our research team. We probably have about 120 people in our CIBS center, critical illness, brain dysfunction, and survivorship. We are a group of people that started with two, myself and one nurse. Actually, then I should add three, a mentor. So a mentor, me, non-gray haired, not as old as I am now, and a nurse practitioner who just graduated with an acute care nurse practitioner degree. And then we grew to about 120 people. And what fun we have trying to unpack and answer questions. In this talk right now, I'm going to tell you about the second column on the right. The first column were the first 25 years in critical care. And during that time, we were constructing, building, adding, complicating the way we cared for people who were dying of sepsis and acute respiratory distress syndrome, ARDS, et cetera. But in the second 25 years, we started deconstructing critical care. And it was that deconstruction, that de-implementation where we pulled things off of the patients. And Dr. Schnapp, you said last night, nothing has changed recently in critical care, but respectfully, I kind of disagree in that I think you were implying that we haven't added a lot, but what we've learned is how to remove. We learned how to remove things quicker. And when we remove things more quickly, people get back to their land of the living faster. And we've shown some dramatic improvements in the ability for somebody to survive critical illness, and not just survive it, but to survive it wholly and to get back to their baseline of life. And it's easy in the ICU to go in there and do a bunch of stuff and then keep doing it. But what we've learned of the arc of critical illness is that this is the increase of things we add, the ventilator, the dialysis machines, et cetera. And we used to kind of remove things over here on day 7, day 8. What we've learned, and the biggest change in how we manage critically ill people around the world in the past 15, 10, 5, very recently even, is that we now move that back end up here on day 2. So the second that sun rises on the second day, we start pulling things off, because we really, really injure people when they're receiving our care in the ICU. There's a lot of iatrogenic injury. Now, because of it's a research day, I decided to add in one of my favorite teachers, and not personally, but because I've read his books, Howard Thurman. In 1949, this theologian, civil rights leader Thurman wrote, "There are 2 questions we have to ask ourselves. The first is, where am I going? The second, who will go with me?" And then he added, if you ever get these questions in the wrong order, you're in trouble. And I would say that at the beginning of my life as an academician, I did not have them in the right order. I was paying more attention to who I was hanging around than where I was going. And it took me some real intense discernment to ask myself, who am I? Kind of Augustine used to pray, Noscum te, noscum me, that I may know you, God, that I may know myself. And what I had to do is focus on that second part, Noscum te, who am I and what am I doing? And I pose that to you today because I want you to be thinking in the upcoming weeks and months about this idea of discernment and figuring out exactly who you are and what you've been called to do. Because in the answering that question, the path of research here at Wisconsin will be improved, optimized, and the contribution you make to the world will be as great as it can possibly be. This is Teresa Martin. She was one of my first patients when I was an intern at Wake Forest University years ago. I went there because my wife is a pathologist and we couples matched. And we went there not having any idea what was in store for us. And I met, on the month that I was caring for Teresa Martin, a man named Ed Haponic. Ed Haponic was a third-generation bronchoscopist in the world. First generation was from a Japanese physician who invented bronchoscopy. The second one was Ko-Pen Wong at Johns Hopkins, and he taught my mentor, Ed Haponic. And so as a person who wanted to go into cardiovascular disease and lungs, I thought this is the guy. I tell mentees to be a sucker fish on the bottom of a shark. Wherever that shark goes, you're attached. And that's what I do as a mentee. And I attached myself to Ed Haponic, and he helped me realize where I was going to go with this research. She was paralyzed in a coma, receiving over 125 milligrams a day of benzodiazepines and morphine. In EDDB, I call it every deep drawn breath, EDDB. It comes from Steinbeck's East of Eden. Raise your hand if you've read East of Eden. Oh, fantastic. It's an amazing book, isn't it? Nobel and Pulitzer Prize winning author and book. It's about the true essence of humanity and what we can see in the highs and lows of the human condition. And so that's why I chose Every Deep Drawn Breath for this story, because Teresa was in the lowest of lows in the human condition. And one of the reasons that was so sad for me as a person was that I contributed to her downfall, because I did things that hurt her, basically on this sentence right here about the 125. I created an immense amount of iatrogenic injury for Teresa Martin. She ended up with 8 chest tubes, blown lungs, severe cognitive impairment. And in the book, I talk about how when she came back to see me in my first ever post-ICU clinic, she was in a wheelchair, 25 years old, couldn't walk, couldn't talk, couldn't go back to work. I had contributed to the destruction of her body. And I call that now malignant normality. Malignant normality is when we accept status quo as good enough. And what you are doing here in Madison is refusing to accept status quo as good enough. You're saying to yourselves, by all those posters out there, what we already know isn't enough. We have to know more. We have to push the boundaries of science. And I have to add, we have to push the boundaries of science and humanism. And probably the number one most important thing that I have watched evolve in my area in the ICU is that what has changed is that we now recognize that our technology will never be enough. It has got to be steeped in this humanism, this getting on a knee with a person and holding their hand and looking in their eyes at their eye level and knowing that my entire purpose of being here is to serve you, is to reduce your human suffering. And I cannot do that just by picking the right antibiotic or the right ventilator settings. And so that's really the foundation of this work. When Teresa was there with her son, Travis, she thought she was going to have a great life. But instead, in EDDB, I recount, because I reconnected with all these people years later, that he spent his entire childhood getting her wheelchair in and out of the trunk. And he had to do a lot of work to get through that trauma. I myself go to Al-Anon. I've had a lot of people with addiction in my life, and so I attend 2 Al-Anon meetings a week. I've got a sponsor. I live by the 12 steps, and we say it works if you work it. And the first time I talked to Travis, he told me, I've done the work. And he's living a very happy life, but it started out pretty hard. So these two figures here show how we depersonalize people, whether it's a single person coming in with colors and bright lines down to depersonalization of Teresa Martin, or an entire ICU where I depersonalize all of them up there to where they look like just people on ventilators dead other than the monitors who tell us that there's a heart beating. And we did that. And for me, I designed a study. My first ever research project was this one I'm showing you here. I designed this study with Ed Aponic. You see, he's the senior author, because I was so hurt by the fact that I didn't know what I was doing with Teresa Martin. And so we designed the study, which they're now known as SBTs. Anybody in the ICU who practices in ICU knows what an SBT is. You see the word spontaneously here at the back end of this title. I cannot take credit for the S in the SBT, although it was derived partly from this paper in the New England Journal, because Martin Tobin, a very famous pulmonologist, was the reviewer of this paper, and he's the one who said you should put the word spontaneously in the title. So he came up with the idea, not me. Once again, I look at the world with two eyes. One is for non-attribution to me on this, because Tobin said S, not me, because Ed Aponic was my mentor, teaching me, not me. So one eye is non-attribution, and the other one is attribution for those who have helped along the way. J.P. Kress, a few years later at the University of Chicago, instead of stopping the ventilator once a day like we had done, he stopped the sedation once a day. And then after Malcolm Gladwell came out with his book, The Tipping Point, and he talked about how the message should be sticky, I thought, oh, okay, instead of sedation vacations, let's call them spontaneous awakening trials. Then it'll be a spontaneous awakening trial, spontaneous breathing trial, step A, step B, SAT, SBT. So we kind of invented that vernacular because we thought that would be sticky and easy to remember. So this is how everybody's contributing, you see. So in your research day, remember, we're all involved. Ann Patchett, famous Nashville author, wrote in State of Wonder, in science, never be so focused on what you're looking for that you overlook the thing you actually find. When I was a resident, Ed Aponic asked me, Wes, can you go to a research conference for geriatric and pulmonary critical care meeting? It's going to be down in St. John, Virgin Islands. I was like, that sounds like a hardship, but I guess I can do that. And I'll tell the story later in more detail, but basically we analyzed data for a bunch of days for me to get ready for that so I wouldn't make a total ass out of myself. And in the end, we saw things that we just had not expected at all. And I was pretty shocked at what we found. And yet, that to me was the key, was that we learned something we didn't expect to find, and in so doing, we thought to study delirium. And that's how we got to that story, Blair. And it's so amazing that you're studying delirium on a K Award here at Wisconsin. I think your university should be very, very proud of what you're doing for this area of brain science. So delirium is a disturbance of attention and awareness accompanied by change in cognition, DSM-5. In the world of delirium, we didn't have a way to measure delirium unless you could talk to somebody. That was the big problem. Sharon Inouye invented the CAM at Yale years ago in 1990. And I said, well, I can't use that because I went to the library and every article in delirium said mechanically ventilated patients were excluded. Just over and over, same sentence. It was just nauseating and just maddening. I thought, well, wait a minute, like these are the most delirious people and everybody's excluding them. We've got to figure out a way. So we did that. We came up with the CAM ICU, the Confusion Assessment Method for the ICU. It's a very sensitive and specific tool. And then we needed to accompany that with an arousal scale. So Plum and Posner defined consciousness as arousal and content. Arousal and content. So CAM, I figured, is doing the content, but what's doing the arousal? So that became the Richmond Agitation Sedation Scale. I like things about research that are stories behind the story. Kurt Sessler came up with this originally in Richmond, Virginia. He was going to call it the Sessler's Agitation Sedation Scale, but that would have been then Sessler's ass, so he didn't do that. Instead, he called it the RASS. And now the RASS is the most famous sedation scale in the world, thanks to Kurt. And we use these as sister instruments for arousal and content to understand consciousness. It turned out when we started using this a bit more, the third JAMA paper in this series, this is all from my K Award, the first paper 2001, second 2003, and this one 2004, where we found that the delirium was a predictor of mortality. So the more patients were delirious, the more likely they were to die. And that's after, you could say, oh, Wes, of course, like they're sicker because they're more delirious. No, we adjusted for all of that. And actually, here's another, I'm gonna just dribble out these research things all day long. That fourth word, predictor, that is not the word that we submitted the paper with. We submitted it with association. And the statistical reviewer, I don't know why it's shaking, the statistical reviewer said, your methodology is robust, and you've actually shown it to be a predictor. You've gone way beyond association here. So the statistical reviewer at JAMA made us change that word, kind of like Tobin put in the word spontaneous. So they were right, but we were kind of, like we didn't want to overstep. So, but I was super excited when that reviewer told us to do that. So at this point, I'm adding this in because it's a research day, and there's a lot of people in here trying to figure out their noscum te. People were saying things like, Wes, this delirium stuff does not belong in critical care. Like, you're going to trash your career. Many people told me that there was no hope for this, it wasn't going to get funded. And I took it really personally. It was a tough thing because I kind of thought for a moment that this was where I was supposed to go. But all these senior people were saying, no, stick yourself in here. That's what we do. So I didn't know what to do. But then Donna Hilly came along. Her sister wrote me this note afterwards. Donna is in the stripes, and her sister, Teresa Wittenvile, is in the white. She says in the middle, she's lost her spark. This woman had just a short ICU stay for ARDS. She's lost her spark. She was such a personality. This woman was a CEO on Music Row, very well known, pictures with the President of the United States in her office, etc. She has memory problems, some long-term, mostly short-term. She looks older, like an elderly woman. She's fragile and vacant. And I read that email and I thought, no, I'm not walking away from this. There's something going on in the public health realm. And I studied public health at the Tulane School of Public Health and Tropical Medicine. And I thought maybe this is a public health crisis that nobody's recognized yet. And so my mentor started pointing out to me different things. And in one of our throwaway journals, it said this. It said, diffuse anxiety for the continuous calm in the ICU. And I thought it was, okay, we're just sleepwalking into this. Like, we just think, oh, just add as much of these drugs as you can. And everybody in the unit was on these drugs. And what I'm going to tell you is that we then set about to do over a decade of research trials published in the Lancet, New England Journal, and JAMA that undid this. And the goal was to get care to be as safe as it could be. But what I'm going to continue to tell you is that COVID undid what we undid. So COVID put it back. In fact, I just reviewed a paper. Well, it's already published, but I was reading it yesterday because I'm going to be on a podcast next week about this paper called the A2B trial in JAMA. And in this trial in the UK, which had 41 ICUs, 98% of people enrolled in this 1,400 person trial, 98% were on high-dose propofol and narcotics both, which is not required in the ICU, maybe for the first 12 hours. But this is 2 to 4 days in, they're still all getting that. So the saddest thing that happened in my life as a researcher is to watch research where you've proven something get undone by the pandemic. And I came home to my wife and I said, I got to quit. I'm tired. And she said, you can't quit until you undo what got undid. I'm not sure that was grammatically correct. But so we're working very hard, and we want to work with you to fix this problem and get people back to a land of safety. Because a long habit of not thinking a thing wrong gives it a superficial appearance of being right. And that's what we do in medicine too often, is we accept the status quo as good enough when it's not. We proved that benzos were independent risk factors for transitioning to delirium many, many years ago. One of my mentees, Pratik Pandarapandi. And we went on to prove that in the black bars, if you randomize somebody to alpha agonists, that approach versus a GABAergic benzo is better. The black bars being lower, meaning less delirium. So maybe we should get away from GABAergics. And we did get away from benzos. In that UK study I just cited, nobody was on benzos. So we did fix that to some degree. It's not like benzos are a medical malpractice, but they are definitely unsafe in many patients, and not because of the first 10 minutes, but because of what they do weeks and months later. But after this, we then decided that maybe it's not only about the drug, the specific drug, but about the approach you take. So we put in this study the SAT-SBT model in place, and Tim Gerard, one of my mentees, was the first author on this paper, and we showed for the first time in critical care, in any research in this area, that stopping a drug could improve survival. In this case, the blue bar is higher survival by a lot. Number needed to treat of 7 to save a life. 15% absolute improvement in survival at the end of a year. That's a huge difference. Cardiologists would dream about a mortality advantage like this, thinking that we're happy to get a 1.5% absolute improvement, which is you're going to see 30% relatives, but this is not relative, this is absolute. And not only was it improvement in survival, but also in length of stay by 4 days in the ICU and a hospital length of stay by 4 days. So basically putting people in the ICU where you're going to stop every day the sedation, and then you're going to stop the ventilator, SAT-SBT, awakening breathing, as opposed to not doing that stopping of sedation, came up with all these big changes. And you think, okay, that's pretty convincing, but the Laurent Brochard in the editorial wrote, I'm not totally convinced. Not totally sure. So this slide right here is to show you that research is fraught with ups and downs. So in J.P. Kress's study at the University of Chicago, they went from 90, I'm not sure this, I don't know if there's a pointer or not. Anyway, they went from 90 to 53. They cut it in half. We went from 84 to 54 milligrams a day of benzodiazepines. And then a physician in Canada did the sleep trial, and it didn't work. They said, we're going to stop the sedation, and at the end of the day, they published in JAMA, but it didn't help. And when you go in the paper, you look at what actually happened. And I went to the hospital, Western in Kentucky, and I said to the nurses, oh, by the way, you were part of that trial, right? And they said, oh, we hated that study. I said, what do you mean you hated that study? Oh, we hated that study. They made us turn the sedation off. Tell me more. Oh, well, we turned it off when they were there. But as soon as they'd walk away, we'd just turn it back on and crank it back up. And they said that outright to me. I'm like, oh, okay, because that explains why in the control arm, you went from 82 up 20 milligrams to 102 in the intervention arm. But the main message of the paper was, oh, this turning off sedation doesn't really work. Well, no, it doesn't work because you increased the amount of sedation. So this is the stuff that's embedded in research papers that you don't fully get. For example, that A2B trial I just discussed, it was supposed to be a trial of dex or clonidine versus propofol. Get this. And they said in the conclusion, dex and clonidine does not improve over propofol. That, if you read the JAMA paper, that's what you said. Oh, it doesn't work. Guess what? 75% of the people in the intervention arms got propofol. And a lot of sedation, very deep sedation. So there wasn't a separation of groups. So everybody in here who's thinking of research, think of this. People come in, you randomize them, you separate the groups. That's the whole thing. Can you separate the groups? If you don't separate them much, you're not going to see a difference. If you separate them a lot, then you can test your hypothesis. You may still not see a difference, but you're going to know the truth. But you won't know the truth if you don't separate the groups, as was done in that third bar there. So we know from other researchers, Shahabi in Australia, that deeper sedation is dangerous. This one shows that quite well right here. The deeply sedated dashed arm has a lower likelihood of living. And so at this point in research, we knew that delirium was an independent predictor of death. We knew that more delirium was higher mortality. There was a dose response. The benzos increased delirium, and that we needed to reduce delirium probably by changing time on a ventilator. Those are some things we knew. We didn't yet have a connection in our research track with brain long term. But Mona Hopkins, a wonderful neuropsychologist from Utah, as I said, non-attribution, full attribution. It was her idea. She came up with this notion that the ARDS patients are leaving with brain dysfunction. Now that's a sense I need explaining. That somebody's fine in life, and then they get a problem here. So they come to me and Dr. Schnapp, and we see them in the ICU, and we intubate them, and everybody's thinking, okay, this is our job. This is our job. But then we show, oh no, this problem left with this problem. Oh, they acquired a new disease. Yes, they acquired a new disease. And that's what we would set out to study, went to the NIH and got this large NIH grant. We proved, and this is the one that ended up contributing to the creation of the ADRD term. They cited this paper, that at the end of the day, that TBI is traumatic brain injury, AD is Alzheimer's disease, that these ICU survivors, only 6% of whom had any baseline cognitive impairment. Now the median is down around TBI and AD in terms of neuropsychological function. This was big news. In fact, the editor to the New England Journal, Mary Beth Hamill, said, well, Wes, what about people younger than that? And so, I take the slide out. We created another slide that has people who are just 30 and 40 years old. And the 30 and 40-year-olds also have this. And it's like, wow. Al Jazeera, everybody all over the world picked this up. Over 1,000 news agencies said, young people in the ICU can leave with a brain dysfunction. So this man wrote to me, 32-year-old sepsis survivor's husband. He says, doctor, she's not all there. The width, the comprehension, the concentration, haphazard at best. And he goes on to say, like, is this it? Is this my wife now? Our new normal? And that's why I couldn't walk away from this problem. Oh, here it is. So on the left, you've got the 30 and 40-year-olds. And that's scary. That somebody could come in with that young of a brain with full neuroplasticity and leave with that problem. And delirium was the big predictor. The duration of delirium was the big predictor. So we knew we had to do more and keep going. Others around the world proved this. I'm going to start going a little faster so we can finish with Q&A. Mild and severe dementia resulted from delirium. Long-term cognitive impairment resulted, LTCI. See, we used to not call it dementia because the dementia world didn't want to hear this. The dementia researchers said, you can't use dementia. That's our term. We said, well, it looks like a dementia. It tests like a dementia. And so we used to use LTCI, long-term cognitive impairment. Now it's fully accepted that we say it's a dementia illness. People end up having pretty remarkable atrophy after a lot of delirium. Here's an example of that. And all this assimilated, as I said earlier, Dr. Vasilevskis helped us produce this program into this bundle called the ABCDEF bundle. A is analgesia, B is both, stopping drugs and vent, C is choice of drugs, D is delirium, E, early mobility, getting people up and out of the bed, and F is family. And this has been very well vetted by all these New England Journal, JAMA, and Lancet papers, the B, the C, the D, the E, the F. Post-intensive care syndrome is the overall mnemonic for this rubric of what happens with the brain and the body after critical illness. And you can see I'm only listing New England Journal, JAMA, and Lancet papers here. There's a lot of literature on this, but it's still under-recognized pretty dramatically. These are papers just for the bundle itself, just for the ABCDEF bundle. We have probably 30 plus papers in this area. So there's a lot of literature. And what I say in the people post-pandemic is I say, we've got the science. The science is already there. We just have to fix our culture. Because our culture is, I want that bed tidy, I want that sheet taut, I want that person not responding, and I want a total control of this human being. Because awake and moving is messy. In the ICU, we like things tidy. Tidy is dangerous. Tidy is scary. Culture eats strategy for breakfast. You can put on paper, we do the A2F bundle. We do that. But I measure what you're doing? No. No soup for you. These are data from 6,000 patients in the Sutter Health group. You can see on the x-axis is percent compliance. So as you go from 0% compliance, 20, 50, 80% compliance, same graph, both graphs. On the y-axis, you've got survival. So more you comply with the bundle, more survival. More you comply with the bundle, more freedom from brain dysfunction. Very dramatic dose response. And dose response is critical in science, as many of the researchers in this room know, and we've got that here, and that's after adjusting for severity of illness and other things. That's 6,000 patients. This study is 15,000 patients. 15,000. Brenda Punn, amazing nurse. She's the first nurse that I worked with. I told you it was me and a nurse. That's Brenda. We've been working together for 30 years. She's amazing. Her initials were BLT before she got married, bacon, lettuce, tomato. And she shows in this paper that the higher you go in compliance, now on the y-axis, the greater likelihood you have of being discharged from the ICU, the hospital, the lower likelihood you have of death. And as you go up with compliance, you see drops, now on the x-axis, drops in coma, delirium, and restraint use. As we were creating this 15,000 person network in the United States, funded by funded by a billionaire who himself had delirium, we said to ourselves, you know, one thing is going to go in the wrong direction. It's going to be pain. Because if people are awake and not delirious, they're going to tell us about their pain. And that panned out very significantly. So this is not that we want to have somebody in pain, but we want to know about your pain. Back to humanism. If you are suffering, we need to know this. When you're suffering and delirious, you can't even tell me about it, and you're still having suffering. But now we can know, and we can do something about it. Less ICU readmissions, less facility discharge, nursing home transfers. This is going to be a short quote about antipsychotics. I'm going to finish with antipsychotics, and then I'm going to bring the talk to a close, and we're going to take Q&A. This is an intensivist, Paul Wishmeyer from Duke, talking about his own experience in the ICU getting Haldol.
I think they realized I was delirious, and I remember them even talking about it, saying, we can fix this, and giving me Haldol. And I got the Haldol, and the first night I got it, about 15 minutes later, my room suddenly became very bright white, and I felt like I fell through 3 glass floors, and my body shattered on the ground of my now 3-level hospital room, and every piece of my body, which would look glass, had a tag on it. And I had to walk up and down the stairs of my now multi-level hospital room, it seemed all very real at the time, and put my body back together piece by piece over the next 6 hours.
And yet, for 50 years, we thought that drug would reduce delirium. This is no diss on Ned Kassem. I mean, we're all researchers. We're all part of something that I consider very holy. And I don't mean religious holy. I mean humanistically holy. Like, we are all part of the story. And you are introducing yourself into the story. Ned Kassem, over 50 years ago, a stogie-smoking priest psychiatrist at Harvard, MGH, came up with the idea, maybe we should use Haldol for delirium, and he did. And this is the original paper. I found this in the library, in the Royal College of Surgeons library. I've been looking for it for years. I finally found this abstract. And we didn't know if it was true or not, but everybody was doing it. So we set up this study and eventually published it in the New England Journal of Medicine that showed that Haldol, whether it be a typical Haldol antipsychotic or an atypical antipsychotic, in this case ziprasidone, that neither of them improved delirium at all. So just to show you how some of the things that we think are right, even for half of a century, aren't right. You can figure that out. That's what you're going to do, is set up the research to help us uncover that. You know, I heard the story of warfarin being founded here in Wisconsin. What a beautiful story that is, but that's not your only story. You've got lots more stories to tell. So I'm going to keep going here. This is hard, but it's mainly it's hard because it involves a change of culture. So this is a woman in Poland with a grocery cart, and her ventilator is in the grocery cart. See, she's intubated. Her husband's in the blue. So here you have what I would call an ideal look at what critical care should look like. This woman is too sick to come off the ventilator, but she's too human to be left in the bed. She's too much of a body, mind, body, and spirit to be left there to acquire these diseases. So instead, her doctors and nurses and the team said, no, we're getting you out of this bed, and your husband will be with you, because the family is critical. It's not a luxury to have family with you. It's part of your healing process. So your husband will walk with you. We're going to put all your stuff in a grocery cart because we don't have the means, but we're going to do it anyway. What's happening in your ICU today? Are the people out of the bed? Are they awake? Because in those 41 ICUs in the UK I told you about, they were in bed, asleep, not asleep actually, in a coma, drug-induced coma, and that is not slow-wave sleep. That is slow-wave sleep deprivation. These drugs strip you of healing anabolic sleep. So we have to ask ourselves, what will we do? I wrote that Good Samaritan bullet here because there's a study. I can't remember if this is Dan Ariely or Malcolm Gladwell, but at MGH they do the study of the Good Samaritan. And they have all these people come in who are going to be the teachers. And they interview them and they say, okay, fine, you're going to be good. You're going to be good at this. There's a classroom across town, and you've got to get there by 11 and then teach about the Good Samaritan story. And halfway there, they put a choking victim on the way. And for the ones where they say, you've got 2 hours, you've got plenty of time, they stop and take care of the choking victim. But half of the people, they say, oh my God, we took too long with you. You're supposed to be there already. They're already waiting in the room. You got to hurry up. And they tell them, they change the dynamic of when they have to be there. And they go, oh God, so sorry, I can't help your choking victim. And they run on. Because what we do is dependent on context and time. And so context and time changes how we behave. What we have to figure out is a way to set ourselves up for success, so that regardless of context and time, our patients are not the victims of us stepping over the choking victim. And that's what this is all about. Goethe said, knowing is not enough, we must apply. Willing is not enough, we must do. So these are some thoughts that I have as a result of my research over these years. I've learned this phrase during the pandemic, cada persona es un mundo. Each person is a world. And I'm going to stop because I want to take Q&A. There's more slides here. Basically, let me give you one last story, one last example. This is Janet Keith. Janet Keith had necrotizing fasciitis of her face. We did 21 surgeries on her face, and each day I would kneel down with Janet, and I whispered to her, Janet, you've got to get out of this bed. And we're going to get you out of the bed. Yes. She'd go, no. I said, yes. You got to get out of the bed. And she had this picture next to her bedside of her below the Eiffel Tower. And I said, Janet, you are a refined badass. And she remembered that term. And she later said, why did you say I was a refined badass? And I told her about the Paris picture. She didn't even know that. And I said, I don't know why I said it, but I just thought I've got to motivate you. And she's so genteel, this woman. And we're so close. She still writes to me. My card has my cell phone on it, so my patients call me. And I was just with her last week. Every day we got her out of the bed and we walked her with the bundle. And on the day that she finally passed her SPT and was extubated, I took this picture. Now, her room was at the back of that hall, back by that sunlight. Now, you think about a woman who has neck fash and has had 21 surgeries on a vent. On the day she's extubated, is she walking all the way down the hall? Not if you don't get her up. The reason she's walking is because we did it the day before that, and the day before that, and the day before that. So we have to have an eye when we're in the unit of that person the day after they are intubated. They're intubated on a Monday. We say in the IHI world of quality, we say, what can you do by Tuesday? What can you do by Tuesday? Intubated on Monday, Tuesday morning, that sun comes up, bam, removal of stuff. And now you know it's wholly evidence-based on science and humanism. Thank you for your time today.
Thank you for a great talk. I know we'll take some questions from the audience and online. I wanted to start by asking a little bit more about thinking through kind of the post-COVID world. And you alluded to the fact that you feel like COVID has made it even harder to kind of do some of these best practices. I also worry about some of the kind of mistrust that exist even more so between kind of patients and the healthcare system. What guidance do you have for kind of people as we think about kind of pushing forward and kind of getting back to a better, state?
Well, first of all, Blair, thank you for the work that you're doing. I'm so proud of what you're doing. It's amazing. Isn't she great?
Thanks.
Let me start with a story. You brought up misinformation, disinformation, and people mistrust. I was with a woman in the ICU who was huffing and puffing on a non-rebreather and then went to high flow. And she had COVID pneumonia. And she said to me as I was caring for her, "Doctor, do you want to know why I didn't get the vaccine?" I didn't plan on telling this story, by the way. It's not a plan. But as you were asking me, I just thought I should bring to life this question you're asking with a story. And so I knelt down and I said to her, I said, if you want to tell me why you didn't get a vaccine, that's your business. We're here for you. And so she proceeded to say, I didn't get the vaccine because the man on the TV said they were trying to get rid of people like me. And what happened to my brain was, it's not her fault. She was given misinformation, or in fact, in that case, disinformation. And, DYS, pain, disease, error. She was led down the wrong path by a figure of authority. What am I to do with that? Rage has no place with her. It's a place of service. So I said, we will not leave you. We will be with you. One of the things patients fear is abandonment. And we have to absolutely focus all that down into that spot in that one moment and say, I am here with you. We will not leave you. We'll be present with you. And then she said, will you tell my family to get the vaccine, blah, blah, blah. So we as a medical community have to say to ourselves, the current climate that we're in, it may be maddening, it may be frustrating, it may be scary, but this is going to be changed by us, one person at a time. If you read Francis Collins's new book, A Road to Wisdom, it's great. I just conducted with our pulmonary critical care fellows, a book club of his book, Road to Wisdom. It's 6 chapters, so you can do 1 chapter a month. It's pretty easy. But in there, in the end, his concluding, spoiler alert, is that this comes down to the individual person doing individual change. And I think that what we have to do is say to ourselves, we know the science, but we also know the humanistic piece, and they go together, and we are going to do our part.
Thank you.
Does that make sense?
Yeah.
Yes. Other questions, please. And don't be bashful. Questions are here. I deliberately cut out about 10 slides, so we have plenty of time here.
Thank you so much for that fantastic talk. I loved it. I love the quote that you put up there about culture eats strategy for breakfast. Can you speak a little bit to how you gained buy-in from your multidisciplinary team to shift culture within your unit to accomplish all of this?
Sure, that's a really important question. And I think it's empty for me just to say, do it. So I have to unpack, how do you do it? And how you do it is that you do PDSA cycles and small tests of change. So what I mean by that is that you have to plan, do, study, act. Many people in this room know what a PDSA cycle is. And then this idea of small tests of change. So what I learned through many, many mistakes is that you can't say with a declaration from on high, no matter how important that leader is, there are many leaders in this room here, they can't just tell you, this is what you have to do. Instead, you have to say, what can you do by Tuesday? So we want to, here, the erroneous way that we set out to try it was, okay, on April the 1st, we're going to implement the A to F bundle. And then on April 2nd, it all looks the same and nobody's done anything. But on April 1st, it now became the official rule of the unit that you're now waking people up, getting them out of bed, stopping the drugs, et cetera. So instead of that, what we learned with these 100 ICUs around the United States through a 2-year program was that the way to success was instead each person had to come up with one thing they would do by Tuesday. Find a nurse, a doctor, a patient, go to that bed, and with that one patient, try something different. And then learn from it. So you're planning, doing it, studying it, act to change. And then on Wednesday, you go back and do it again. And then on Thursday, you do it again. So you just say, okay, Tuesday, Wednesday, Thursday, small test of change, PDSA, okay, that's good. One nurse, one doctor, one patient. So, but we're going to do better next Tuesday. So pick a different patient next Tuesday and do the whole thing again. And do that for several weeks, playing the long game with the same nurse, same team, different patients. And then some of the other nurses are going, y'all are walking in I can't, my patient walk. And eventually it kind of catches on. You go to a second nurse, a third nurse. So definitely do not try and do it unit-wide changes. And this goes for any kind of large-scale change in clinical practice, is that start small, and I say micro hills rather than climbing Mount Everest. I hope that helps. Thank you. Other questions?
Like there's one in the back.
Thank you for your talk. I'm curious how you apply your philosophy, particularly with your Howard Thurman quote, to very protracted and morally injurious cases in the ICU.
Yes. You referred to the Howard Thurman quote about where am I going, who am I going with? Yeah. Wow. And you mentioned protracted and morally injurious. My wife said to me, Wes, something is wrong with you. That's obvious. Jess Giles, my good friend and second-year resident here, knows that there's something wrong with me. Jess, it's good to see you. She said, something's wrong with you. I said, no, I'm fine. She goes, no, there's something changing about you. This is my 40s. I'm 61. In my 40s, she was saying this. And I was of the mindset, I'm good to go. I'm an ICU doctor, death, life, whatever, like I'm there to help. But as I kept hearing from her and realizing that things were not good inside me, that I realized that I had been morally injured. And I had to start doing the work on myself to find out how I'd been injured to get healed again. And so one of the things that happened with me with that Howard Thurman quote is I thought that I could just be part of this whole group of people, but I didn't know where I was going. And so because of that, I just thought I'll just keep going and never unpack any of it. The med students, Jess was a member of a neat group of med students at Vanderbilt, and they told me one day, they said, we had a talk by a neurosurgeon that, and this isn't specific to neurosurgery, but it just happened to be a neurosurgeon, we said, how do you deal with moral injury? And he said, oh, I put it in a little box, I take it out in the field and I bury it. That's terrible advice, okay? No, that's not what you do. But I would say in short, I had to tell you all that to show with you that there is really, really a lot of difficulty in what we do in medicine. And we see the hardest things, and we see people come in from injury of other people and also the systems injuries that they have because they're a very vulnerable population. They don't get the right care, and then they end up way injured when they come to us. And that's really, really hard. And what I hope is that two things will occur. Is that one is that we as a community will say to ourselves, we will not accept this malignant normality. It is a malignancy. It's a malignancy of thinking and acceptance, and we can't. So we have to change, and that comes from research and one patient at a time. But the second thing is we have to say, I will do my part. And as an individual human, I'm going to make sure that I have time away, that I think and do whatever brings me wholeness again, and then I will talk to somebody. I go to counseling now, and I have a counselor who helps me a tremendous amount to unpack these things. So all of that has kept me going, and so even though I'm getting very old, I am fumbling in love with medicine. I've never been more in love with medicine. I have no burnout in my mind because I think it's such a treasure and a gift to be there. And I hope that answers some element of your question. Next question, please.
Wes, it's me.
Hi, Ed.
So great to have you here, and I'm so thankful for your wife to convince you to undo the undoing. And so
Thank you.
I want you to reflect on that. It's been confusing to me from the pandemic. Nobody told us to put benzodiazepines back on to increase sedation and reduce. So what have you learned, and where do we go forward with the next pandemic, and what should we learn about how things did get undone?
Thank you, Ed. I think Mandela said, I hope that your actions come out of hope and not fear. And we were doing our best. I mean, the best we could with the light we had at the time. It was a dark time. We didn't have vaccines. We didn't have PPE. We didn't have knowledge about transmission. There were lots of things we didn't know. And because of that, out of fear, we did do a lot of things that were not just that they weren't good, they were actually super dangerous to the human beings. Putting them behind glass, no family, dying alone. I mean, how many people right now, skeletons, are in the ground who died of loneliness? We can't answer that question. But you have seen people heal with love. So when you remove love, is it also true that people can die of absence of love? Darkness is absence of light. So I think that we did that, and I don't think it's okay. And I don't ever want to live that way again as a physician. Ed, I think that we can learn from this. I do think that we can know that it is never going to be okay again to keep people behind a glass and not have family allowed at their bedside. That's one basic thing that we can know, that was not an okay thing to do to anybody. And I remember the very first patient at Vanderbilt, there was no visitation allowed, and I had a young woman admitted to my service who had lupus cerebritis. She was 28, and she was in that room by herself. She didn't even have COVID, but there was no family allowed. And I said to the administration, we are going to have her family come up. And they said, no, you're not. And I said, okay. And I went down to the lobby, got the family, and brought them up. And I just said, forgiveness later. And I brought the woman in the room. I'll never forget this. I brought the woman in the room, the mother. I said to bring your stuff. She brought her stuff. So I said, once you get in here, you're going to stay in the room. You're not leaving now. And she brought her stuff, and she took off her mask, and I knew her. She was a grocery employee at the Kroger where we shop. And I looked at her and said, oh my God. I said, it's Wes. She goes, oh my gosh. And it was her daughter. This human connection that the three of us had immediately was so big. How could we strip that away and think that we are being healers? No way. So, and then Ed, to speak to the medical part of it, we allowed the drugs to come back in full vengeance. And that was also out of fear. They were broadcasting all these propofol shortages. Most people did not have much of a propofol shortage. It was just like, let's just grab the benzos, make them as deep as we can because we don't want them to pull out their ET tube. So the thinking was, and I mean, I'm an insider, so I can tell you, was they're behind glass. I'm not in there. If they pull the tube out, they're going to die. So I'm going to snow them into Stone Age and not have the tube come out. And it wasn't, oh my gosh, 20 days of a benzo is going to crush their brain, and even if they survive, they're now screwed for life. We didn't let our brain go there. So we have to not think that way anymore, and we have to do the research to make it better again. And on the plane up here yesterday, when I read that study, I thought, I didn't want to study this anymore, but yes, I'm going to come back and study this again. And we're going to do something called an Awake and Walking ICU study. Thank you, Ed.
Thank you so much. This was an incredibly inspirational talk. I know there's a lot that I will take, as I'm sure others, into both my clinical practice and research. I want to thank you again.
Thank you, Blair. And y'all have a great day.
Thank you.